And our next presenter is Dr. Lewis Nelson. He's he's professor and vice chair for academic affairs in the Department of Emergency Medicine at NYU School of Medicine in New York. And he's going to talk to us about guidance for opioid prescribing, lessons learned from the New York City experience.
And thank you, and thanks for all being here and taking the time to come and hear this stuff. Obviously, this is something that's near and dear to my heart, and obviously to many people in the room as well. I think we all probably share a concern for this problem, and hopefully maybe we could work towards developing some sort of solution. You know, I have no obvious conflicts of interest in terms of taking money or working with any unsavory characters, but I would say that maybe everybody that's in this room has a conflict of interest, because either we want to see more and better or more aggressive pain management, we see less aggressive pain management and less drug abuse. And although I believe as an emergency physician we have to treat pain, I also believe as an emergency physician that we really should be very, very careful when we give out pain medications to people, particularly opioids. And nobody's really ever gotten addicted to ibuprofen or acetaminophen, best I know. But clearly this is a big problem. It's something that, and I say this a lot, prevention is really the key. And I could say one thing for sure. If you never took an opioid, you would never be addicted to opioids. Right? So just keeping that in mind, this is how I kind of framed the thoughts as we went through. So, Knox earlier mentioned the study by Nora Valka that was published in JAMA a few years ago and showed how emergency physicians are big prescribers of opioids in a certain age range. Believe it or not, the number one prescriber of opioids in most age ranges, or certainly in the top 5 in all age ranges, were dentists. Right? And the dentists have been light years ahead of medical doctors and emergency physicians in developing guidelines for prudent opioid prescribing. And if you look, this is just one, or a revision of one that they published recently that kind of gave a stepwise approach to the management of dental pain. And if you read very carefully, it starts with ibuprofen or acetaminophen, and it doesn't really get to an opioid until the 3rd stage of really severe pain. Right? Now, of course, pain is very difficult to identify and to assess, and it is very subjective. But we are all human beings, and we all kind of have a general sense of what pain is and what pain should be and how pain should be managed. And I do think that there's some culture shift in the way that we address pain, which may not necessarily be healthy. Right? If you heard the study that Kavita quoted, I think it was Kavita, about the fact that more educated patients are less likely to get pain medicine, I think that's pretty telling. Right? And it does say a lot about how we think about the risks inherent in taking pain medications, whether it's the risk of addiction or whether the risk of overdose, or even just the risk of blurring our senses for a short period of time while we're taking those medications. So, clearly we have to think about very carefully the way we use these pain medications. They need to be used when people are in severe pain. Nobody should walk around in agony. But I think we have to recognize that people that say they have 11 out of 10 pain are maybe a little bit misguided, because in theory you really shouldn't have more than 10 out of 10 pain, right? And they're probably telling you something. You heard a little from Knox, and you'll hear more perhaps later about the opioid guidelines we put together for FACEP, and you'll know that there's a lot of other groups in the country working on this. And here's just one from the Washington State labor organizations trying to get a handle on the problem with chronic opioid use in workers, right? Because this is a huge source of disability and just tremendous payouts and lost time and other things associated with this. Not to mention, drug overdose and misuse and diversion and everything else that goes along with the overuse of these kinds of medications. Washington State has, because of the culture here, I think for many years, has really had a big problem with the opioids. And they were really the leaders, probably after the VA, which put out guidelines many, many years ago that were not very effective. And actually, they just redid their guidelines a few years ago and have been now cited just maybe in the past 3 or 4 days in the newspaper you might read that a study came out looking at just the huge problem with over-medicating veterans and how it's leading to death from overdose, suicidality, all kinds of problems that they pretty much directly relate to the overuse of pain medications for relatively limited indications. But Washington's really come out with guidelines, and I'm sorry you can't read these very, very much from there. But you can probably pull these down online if they're not included in the packet. But what I want to point out is that when we read these guidelines, we were very careful as we crafted ours to try to copy some of their good points but to eliminate some of the things that we found to be somewhat problematic. Now, both the guidelines from Ohio and the guidelines from Washington State take this approach that are guidelines, right? They're shoulds, right? They're as opposed to mays, right? And when we get to the New York City guidelines, I'll tell you that one of the big problems we ran into is the should problem, right? There are a lot of people very concerned by anybody telling us what we should and shouldn't do. Even though we were emergency physicians in New York putting together an emergency medicine focused guideline, people are very concerned about the ramifications of shoulds. Right? And you'll read some of these things, and these really are devoted a lot more to things you shouldn't do for people with chronic pain. Right? And a lot of them are the things we talk about. You shouldn't refill people's medications when they lose them. You shouldn't start people on long-acting and extended-release opioids. And I could read you a few of these if you want, but basically they really go through very carefully choreographed and thoughtful approaches to managing people with chronic pain. But we really don't always manage chronic pain in the emergency department. Right? In fact, I'd say the vast majority of pain we manage is not chronic pain. A lot of it's recurrent pain, and a lot of it's acute pain. And I am very concerned about people with acute pain coming in and getting started on opioid medication, well-intentioned, of course, but ultimately that might be the person who winds up having a long-term problem, and the one that if they didn't really need the opioid analgesic in the first place, perhaps we shouldn't have given it to them. So we sat down. I organized a group of emergency physicians in New York City, and I happen to work at NYU and at Bellevue Hospital, but I also work in the New York City Poison Control Center, which is part of the Department of Health. So we got the Department of Health interested in this, and the health commissioner at the time, he's still a health commissioner, was a big advocate for really trying to control some of these things, which was good. So with the Department of Health, we put together this panel, and we met several times, and we reviewed the existing guidelines. And we tried to come up with something that would be not prescriptive, really just a set of recommendations, although we did title it guidelines, which got us a little bit of blowback later on as we go down. But what it really does is it just allows people a couple of things. It allows you to kind of think through a little bit the way that maybe opioid prescribing should be done. It allows you to tell patients that, this is what I'm kind of required to do, or I'm really asked to do by the powers that be. It tries to eliminate some of the problems that Kavita and others have described, where it says, last time I was here, so-and-so gave me this medication. Or what we just heard about somebody going across the street to the other hospital and getting a different sort of treatment. So it's nice to have a citywide effort here. Of course, it would be really nice to have a national effort, where we all kind of agreed with some sort of standard that we'd like to set across emergency departments. But it's hard enough to get a citywide effort, let alone a statewide or a national effort. But it might be good. So we really looked at things, simple things such as give short courses of medications, give low doses of medications, don't refill people's prescriptions unless you have a really, really good reason to do it. You could read this. And the other thing we did that I think was quite phenomenal was we put together a poster that's put in our waiting room that sets expectations of our patients. So they're not going to come in and wait 8 hours and then be told we're not going to refill their long-acting prescription, right? And they're not going to come in and say, the last time I was here I got 10 days of medication, because we're only really giving out 3 days of medications for most forms of acute pain. Because you realize, of course, pain goes away. And, if you give 3 days and they need more, they can come back. I mean, no, that's sacrosanct, sacrilegious at least to say that. But I do think that when people have problems, they manage to come back if they need additional pain medication. So we then sent it around, and we got buy-in from the vast majority of academic medical centers in the New York area, and most have signed on to use this. We're starting to try to get follow-up. It's been about a year now. It came out in January, so a little less than a year. But we're trying to get follow-up and see how people are doing with this and see if it's going to really make an impact. It's very, very hard to study these things, as you could imagine. But we are trying to make a difference by giving people a set of parameters that they can use when they try to think about opioid prescribing. It's maybe not the only solution. It may not be the best solution, but it's a solution. It's an attempt. And I think it would be very nice to take this a little bit more broad. Now, the biggest problems we ran into, I'll tell you there were two. One was the should problem, right? We did figure that out beforehand. If you read the guidelines, if I can go back to that, you'll see that nowhere do we say should. We say consider, we say think about, we say do this and that, but nowhere do we say this is what you should do. Because people were very concerned about the patient satisfaction and legal implications and things like that. The other place we kind of ran into trouble was with the rollout. Right? The messaging. right? And if you decide to do this at any level, whether institutional or broader, be very careful in how you tell people it's going to be done, right? So when we roll this out, we had a big press conference, not by my wishes, but Tom Farley, who's the Commissioner of Health, is standing at the helm. Mayor Bloomberg is standing next to him, the mayor of New York City, and I'm in the background somewhere. My dad was very impressed with the picture, but everybody else that saw it and read the article was angry because the way it was rolled out, which should have really been done by me or Stu Kessler, the other doctor standing with me, was rolled out by the mayor, and he used all the words that we didn't want to use, right? He used the should. He said, ERs, his words, will not prescribe more than 3 days of pain medications anymore, period. He said, city hospitals, of which Bellevue was one, will not provide opioid analgesics anymore, which of course was interpreted as the city's against poor people, and it's against drug users, and it's against everybody, and we hate to take care of people with pain. And that's the messaging that the papers took out of it. That's not exactly what the mayor said, but the words he chose were so critical. Even though I spoke to the author of this New York Times article the minute after the meeting ended, before she wrote the article, she chose to use the mayor's words and not mine. This led to statements from FACEP, right, about how these guidelines are misguided and they shouldn't be used. And unfortunately, that was really said in somewhat of an information vacuum. They didn't see the guidelines when they made those statements. They just reacted to the reporter's words, which was unfortunate. So my recommendation to you, if you're going to go through with something like this, they are phenomenal. I tell you, it's my faculty and the faculty of all the hospitals in New York City love these things. I think everybody's very happy with them. I think the only problem we really faced was the should question and the messaging question. So be very, very careful how you do that when you go forward. There was a little bit of a glitch afterwards with the poster. And I know that you have a poster like this in Washington State, and a few other people do too. And the glitch was that it had to do with EMTALA. By putting a poster up there that says we won't treat pain, CMS said that's an EMTALA violation. I'm done. We then, reviewed whether or not the poster actually says the things that EMTALA would prevent you from saying, and in fact, our review at the health department legal level found that it really doesn't. Right? We don't say we won't treat your pain. We do say we won't refill your long-acting extended-release opioids, but there's nothing in the EMTALA rules to say you have to do that. Right? So I think that another thing to think about is if you do want to put up some sort of notification to your patients, just make sure it's within some sort of bounds that won't get you an EMTALA risk of violating the rules. So ultimately, this is where we stand now. And again, I'm happy to talk about this more as we go on. Thank you.